Then bones. So we have from the center we have come across the pleura, and now bones, clavicles, and everything we should scan through, because there can be a lytic lesion, there can be fractures. The density of the bone should be carefully noticed. And in normal X-ray at mid-clavicular line, you can see the anterior ribs 5 to 6 ribs, and posterior ribs 7 to 8 ribs in a normal full inspiration. And in this image, you can see some nodular areas. This is due to old rib fractures. This can be easily missed, right? Nodular areas due to old multiple lateral rib fractures. And at the corners, we have to go through whether there's a humeral head is there, and clavicle, whether there's any distortion or not. Other one is the soft tissues. So there are a lot of requests we are getting in the radiology due to these nodules, right? It's nodule-like area, whether it's a lesion, we need a follow-up or not. So in a female patient or male patient, both nipples can be seen as a small soft tissue nodules. So we can mark the nipples with nipple marker, and we can do the X-ray to confirm this. And the breast shadows also mimic as soft tissue masses, so we have to carefully go through the breast shadows. So in this X-ray, you can see clear hyperlucency in the right side. That is due to the mastectomy. So right breast is seen clearly, but the left breast is missing. So the patient has underwent for mastectomy. Due to that mastectomy, soft tissue is lacking, so the lung will look more hyperlucent. The fat tissue density should be seen over here. If it is distorted, then there will be a mass. So what's here is there are a lot of findings. So the soft tissue in the neck region is replaced with the air lucencies, and the diaphragm is again elevated, and there is a drainage tube also. So this is a polytrauma patient where surgical emphysema is there. Soft tissue is within the soft tissue, air has infiltrated, and emphysema is there, and multiple rib fractures. So once you see the surgical emphysema, we can't give only the surgical emphysema. That is one of the professional misleading. Uh, we have to the search of satisfaction. That means if you find one thing, then that's it. We can close the chapter. No, we have to check for other ancillary features as well, rib fractures, drain, diaphragmatic elevation. So this clavicular fracture. So everything need to be mentioned. So again, a patient with a rib fracture. So finally, the review areas. Here, as I mentioned earlier, the important review areas are the apices, where we can miss the pathology, hyla, when there is a subtle lymph node enlargement. So once you go through all the things, go to the review area and check the apices, hyla, retrocardiac areas, and the lower subdiaphragmatic areas. Those are the 4 review areas to be checked finally. So the last chapter is the lines and tubes. So how to assess if there is an ICU patient or a patient in CCU, we have to assess the lines, whether they are appropriately positioned. So here the ET tube, this is the carina. ET tube is usually positioned 5 centimeter to 2 centimeter, so 2.5 centimeter above the carinal level. If it is positioned at this level, then that's adequate. If it is advanced into the right main bronchus, then it should be withdrawn. So this is the tracheostomy tube. So you can see the flank here. Again, that is also same level from the carina, at least 5 centimeter above. So what's happening here is patient is on ET tube, and you can see the ET tube extend beyond the carina and into the right main bronchus, where the left lung is completely collapsed due to the hypoinflation. Uh, Again, with patient with the surgical emphysema polytrauma on ET tube, uh, and there is a ET tube leakage, or due to the insertion during the insertion of the ET tube, there is trauma to the trachea, which lead to surgical emphysema, and you can see the air along the heart, right? That is called pneumomediastina. So this is secondary or iatrogenic surgical emphysema and pneumomediastina. Other one is NG tube placement. As I mentioned earlier, the esophageal line should be like this along the esophageal line up to the stomach. That is the normal position. So this ET tube is positioned correctly, left to the trachea, going nicely, and you can see the tip within the stomach. But here, again, you can see there are 3 points to check. One is whether at the gastroesophageal junction, the tube has passed, right? And in the tip is also at the stomach. So these are the 2 points need to be clarified. Here, you can see the tip still in the trachea. The ET tube is coiled and it didn't pass the gastroesophageal junction, and stomach not seen. So this is due to the coiling of the NG tube uh, within the trachea. This can be due to tracheoesophageal fistula or esophageal atresia. Again, the ET tube mispositioned within the right bronchus. These are the lines where PIC lines, peripherally inserted central lines. The important thing is when you assess the PIC lines, uh, at the carinal level, the superior vena cava start at the carinal level. So the PIC line should be up to the carina, not beyond that. And if it is uh, any dialysis catheter or chemotherapy related lines, it can extend to the level of cavo atrial junction. Again, internal jugular vein is mispositioned and it is located within this soft tissue part. So the chest drains, there are two. One is for pneumothorax and other one for the hemothorax. Here the chest drain for the pneumothorax should be face upwards, not downwards. So this is correctly positioned. Here the pneumothorax is over here, the chest drain is positioned here, and we couldn't see the costophrenic angles. So we can't decide whether what's the reason for the insertion of the chest drain, since the costophrenic angles are not included. That could be due to the hemothorax as well, right? So in effusion, this is the correct position. It is directed downwards, and it's within the effusion. And the pacemaker lines, pacemakers are usually uh, it can be single chamber, double chamber, triple chamber. This is a single chamber, only one lead is there, and it is the tip is placed at the left ventricle. So appropriately position pacemaker. In addition to that, if you see the humerus, there are a lot of metastasis, right? And the clavicle also not good. This is a prostatic CA patient who had the pacemaker, and there are bone metastasis. So easy to miss. If you have a search of satisfaction, so you can miss this bone metastasis. So finally, the systemic approach. Once you get the X-ray, check the name or left, right, whether it's what sort of X-ray, PAO, AP. That's the first thing. Then go through the RIP, whether it's rotation is there, the inspiration is adequate, penetration is adequate. Then check through the lines and tubes, whether they are appropriately positioned, and check the abnormality. If you have any striking abnormality, if there is a consolidation, describe it early as possible. So if there is an elephant, describe it from the tail to head to tail, describe it nicely. So that is the fourth thing. And here there's a, this is due to the metastasis. I think, again, don't miss the review areas, the lateral parts. Here, the humeral head is infiltrated due to the metastasis, right? So the take-home message is follow the protocols, identify the X-ray, uh, do a quality assessment, assess the lines and tubes, uh, go through the systemic approach, and come to the conclusion. So when you started describing abnormality, describe it completely. If there's a consolidation, describe about the air bronchogram, whether there's any cavities. So describe it completely, and do not allow search of satisfaction. And if you don't pick abnormality in 30 seconds in X-ray, you can't do it in 30 minutes also. So it's waste of time. So maximum time to spend in X-ray is just 30 seconds. With a glance, you should be able to pick the abnormality. And at the end of the reporting, give a conclusion or possible differential. Most of the time, we couldn't come to a conclusion, so better to give a possible differential diagnosis. And if available, compare, always compare with the previous images, uh, and mention about the follow-up imaging, whether the X-ray need to be repeated in how many weeks, and how many days, or whether we need to go for HRCT or CT. Thank you for the attention. I think I took more time. Sorry about it.